Michelle. Well, it's my privilege and honor to welcome Dr. Rachel Brathwaite to our town hall series. Rachel has a Ph.D. in Epidemiology and Population Health from the London School of Hygiene and Tropical Medicine, and a master's in Applied Epidemiology from the University of Nottingham in the United Kingdom. She's interested in conducting research with a focus on early prevention and interventions to improve the physical and mental health of vulnerable and marginalized populations. So very apropos to have her speaking to us here at CAPS. She's been involved in population health research on modifiable behavioral risk factors among vulnerable populations, harm reduction among marginalized populations, and research to identify and prevent poor mental and physical health among vulnerable youth populations in low and middle income countries. She has experience applying machine learning techniques such as prediction modeling to develop tools that can be used to predict future depression among adolescents in low and middle income countries, including Nepal and Nigeria. She's applied these techniques to predict poor mental health among young people affected by HIV in Uganda and to predict poor adherence among adolescents living with HIV in Uganda. In this talk, she'll be demonstrating the application of Lasso, regression, and Stata to predict health outcomes using an HIV-related data set from Uganda. So I'm very grateful to Rachel for accepting our invitation to talk on this topic. I've had the pleasure of working with her for several years now, and she's taught me some really neat stuff that can be done in Stata, including calibration plots. And I thought, you know, this could be an opportunity for us to see how maybe a kind of an intimidating topic like machine learning can actually be done in Stata using some of the built-in commands and user-written add-ons in a way that can show that it's accessible and maybe not as scary as some of us more traditionally trained statisticians and methodologists might initially think when we hear the words machine learning. So thank you very much, Rachel. Please take it away and let us know your thoughts. Thanks.
Yeah, thank you so much, Tor. I'm really grateful for the opportunity to speak to you today, and I want to as well echo my pleasure and gratefulness for working with Tor. Like, he has been a really great resource for me since I started working at iChat. So yeah, it's been good so far. And yeah, so today I'll be talking to you about how I have used prediction modeling, the machine learning techniques in Stata, specifically Lasso regression, to predict poor health outcomes using an HIV-related data set. So just to give a brief overview of how this talk will go, I'll first, give a brief introduction to prediction modeling, and then I'll give a brief background and introduction to a hypothetical research question. So just to make clear, the results in this talk today has not been published before, but I'm hoping that the methods that I'll show you can then use it and apply it to your own data set to answer what question that you may have. And then I'll go on to show you how we use the Lasso regression in Stata 17 and show you a bit about the commands and how you can interpret the results. So just to give you a brief introduction. So what are prediction models? So prediction models are basically tools that can be used to predict an individual's risk of developing a health outcome or any outcome for that matter. And prediction models can provide the absolute estimated risk of a future event for individuals, based on their unique combination of characteristics. So on a more serious note, prediction models involves a series of steps that's designed to create the best model to predict an outcome. And I'd like to refer you to this paper by Ewart Stuyberg and Yvonne Fergori that has been published in 2014 that really outlines the steps you can take when creating a prediction model, and also the steps you take when validating that model. So that paper outlines 7 key steps that you should follow. So the first, what you want to do is to, of course, understand your research question. What are you trying to answer? And of course, you want to then go on to defining your outcome and defining your predictors. And of course, understanding the data that you have available for use. And then you want to move on to defining how you want to code the predictors in the data set. So whether you want to leave it as a continuous or categorical predictor. And then of course, you want to then decide which method you want to use for selecting the predictors. And like we mentioned before, we're going to be using the Lasso regression in Stata. And then once you have done all that, of course, you want to run your model to determine the regression coefficients of the predictors. And then once you have your model, you want to then evaluate how well this model performs. So looking at things such as the discrimination and calibration of the model. And then, of course, you want to go on to model validation. So looking at things like the internal and external validation of the model. And of course, the last thing you want to focus on is how you will present this model for use in the real world. So whether it's through a formula or like a computerized program or online tool, but we won't be focusing on the last point, we'll just be focusing on the 6 steps today in this talk. So, in the field, prediction models have many applications, and in the field of medicine, it can inform a clinician about the risk of developing a disease. It can inform clinicians about whether this patient actually has the disease or not. And of course, if a patient has the disease, it can give guidelines on how, what's the trajectory that this patient is likely to take if they have this disease. And of course, this has many applications in terms of screening. So it can be used as a screening tool. It can support personalized medicine, since it answers questions such as who is most likely to benefit from treatment and who is the most at risk of adverse health outcomes. And of course, when all of these are in place, you can see how it can contribute to minimizing costs to the healthcare system, since it would aid the more efficient use of resources, since you're targeting participants who are, or patients who are at most at risk of adverse outcomes, and especially in conditions where resources are limited, then this can minimize the cost to the healthcare system and facilitate more efficient use of resources. So what are some of the questions you want to ask prior to developing the model? Of course, you want to know who is your target population, who are you making the predictions for? And in this case, we're going to be making predictions for adolescents living with HIV in Uganda. And we want to, of course, then decide what outcome we want to predict. So in this case, I'll be predicting depression. And as I mentioned before, we're going to be using Lasso regression. And I just want to point out that prediction model is not concerned about causation per se. So we're not really concerned about the mechanisms of which predictors and how they work in terms of predicting or causing the outcome, but rather if we include that predictor in the model, it improves accuracy of the predictions. So I'm going to transition now into a bit of the background to our hypothetical research question. So we know that adolescence is a really critical developmental period, and during this time, participants or adolescents are at risk of increased risk of mental and substance use disorders. And young people living with HIV in sub-Saharan African countries, we expect them to face additional challenges as they transition through adolescence and young adulthood, since they live in resource-poor settings. So we know that living with HIV increases one's risk of poor mental health outcomes, and that maintaining good mental health during the childhood and adolescent period is essential for avoiding poor mental health functioning. And for adolescents living with HIV, we know that depression is associated with poor linkage to care, failing to initiate and adhere to medication, which contributes to increasing their viral load, susceptibility to illnesses, and of course, engaging in risky sexual behaviors, which of course would fuel the transition of the virus to others. So given that in countries such as sub-Saharan Africa, where there are limited resources especially in terms of the number of child psychiatrists available, we need to develop alternative non-clinical tools that can be used to help identify and predict patients that are sensitive with HIV are at higher risk of being depressed when needed. And these individualized risk assessment approaches can really contribute to identifying those individuals who are at risk even before they develop the outcomes. So, so that's where prediction modeling comes in. So if you have a prediction model or risk calculator, then you can use that tool to provide the estimated absolute risk of depression for the adolescents based on the unique combination of characteristics. So I'm going to transition now into describing the data set that we have, that we're going to use to answer this research question. And the data set comes from the SUBI adherence study. And this study is, the PI is Dr. Fred Surmala, my mentor at HIV in partnership. And this study recruited participants from areas that were heavily affected by HIV and AIDS in southwestern Uganda. And this was a two-arm cluster randomized control trial. So participants were randomized at the clinic level to either a control condition or to an intervention condition. And the intervention condition received, economic empowerment intervention, so child savings accounts, training on financial literacy, training on income generating activities, and peer mentorship. And participants were on average age 10 to 16 at baseline, and they were followed up once per year for 5 years. So to be included in this study, participants had to be medically diagnosed with HIV and aware of their HIV status. They had to be aged between 10 to 16 at baseline, living within a family, and prescribed ART medication, and also receiving care and treatment at one of the 39 clinics. So we're going to move into defining our research question, the predictors and outcome of interest, and putting our predictors. So what is our research question? So we are interested in determining what combination of multi-level factors can predict depression in 1 year's time among adolescents that with HIV in Uganda. And our outcome is depression as measured by the 14-item version of the Children's Depression Inventory. And in this hypothetical example, I'm just going to define depression as anyone scoring above the mean depression score in the data set. So this is not a clinically, relevant cutoff, but just for the purpose of, showing you the steps in this, in the procedure, I'm just going to define it this way. So we're going to be also using the complete data set in this talk. So the data set comprising of no missing data on both the predictors and the outcome. And this leaves us with a total data set of 563 participants, and 217 of these had our outcome depression, which equates to 38%. So how do we go about defining our predictors? So one way to do so is, of course, to look at the literature. So what is already known about the predictors in the literature? And since we know that multi-level factors influence the outcome of depression amongst adolescents with HIV in Uganda, we will refer to the modified social ecological model as a framework to guide our inclusion of predictors. So this model comprises of different steps, different levels. So predictors at the individual, household, community, structural, or economic level. And luckily for us, the SUBI adherence data set is a really rich data set with lots of data at each of these levels. So we're going to have predictors to include. So at the individual level, we're going to include predictors such as demographic predictors like their age and biological sex, and also behavioral level predictors such as with the use of substances, history of adherence, and also psychosocial predictors such as whether they're experiencing hopelessness, how confident they are in adhering to their medication, whether they have disclosed HIV to someone or not, and also some health-related data such as viral load. At the household level, we're going to look at predictors such as whether they have an ART treatment supporter. We're also going to look at things like family cohesion and whether the type of caregiver they have, so biological or non-biological. And you can see here how the different categorical variables are coded in the data set as well. At the community and structural level, we're going to look at things like HIV-related stigma, whether how strong is their social support network and their distance to the health facility. And at the economic level, we're going to measure things such as their ownership of assets, and we're going to look at things like child poverty and, of course, which intervention group they were assigned to, since the intervention group received savings accounts. So we're going to include that in the economic level predictor. So we're going to move on to specifying the model. So we have already outlined above, the different predictors we're going to include, and we're going to select the predictors using Lasso regression. So now we want to estimate the model. So since we know that not all predictors may be contributing to the outcome, and we are interested in selecting the best subset of predictors of regression from the list above, we're going to use the least absolute shrinkage selection operator, also known as Lasso. And since we have a binary outcome, which is depressed or not depressed, we're going to specify the Lasso logistic regression model. So Lasso is basically, a supervised machine learning method for prediction. And compared to, so the traditional ordinary least square regression, what it does is it estimates the coefficients of the predictors by minimizing the least square. And however, all the predictors remain in the model, and they just contribute to adding variance to the prediction of the outcome. But Lasso determines which predictors are relevant by applying a penalty term called lambda to the least square. And this causes some of the regression coefficients to shrink to zero, thereby including them from the model. And this results in a simpler model, which we want. So looks like my chart is missing. But yeah, I continue. So in prediction modeling, we are concerned with how well the model will perform in new cases, so generalizability. But the traditional way of doing prediction modeling, you would normally split the data set into like a 70% training data set and 50% test data set. But this can contribute to, if we have limited data, this can contribute to not all data points being used in the training and development of the model. So the model will fail to learn the data distribution properly. So one way to overcome that is to do cross-validation, or also known as k-fold validation, and k refers to the number of folds that you can split the data into. So if you have a data set, if you want to do 10-fold cross-validation, what you would do is first, split the data into 10 folds, and then develop the model on the remaining fold that you keep one fold aside, and then you develop the model on the remaining 9 folds, and then you test it on the fold that was held up, and then you repeat this 10 times, holding out a different fold each time. So this contributes to multiple mini train test splits, and then you combine the performance across the 10 folds. So this way of doing this, prevents overfitting by allowing each observation to appear in the training data set so that it can learn the distribution properly. So cross-validation is one way of preventing overfitting, since it improves the ability of the model to be able to generalize to new data. And in this talk, we'll be using 10-fold cross-validation for selecting the lambda, which is the penalty term used in Lasso regression, and also for determining the area under the curve.
It's fine, go ahead, thank you.
Okay, so I'm sorry my picture disappeared, but I had like a cartoon animation that was trying to, predict the next president. And the prediction for each year was so specific to that president and to that year that it was almost impossible to generalize to the following year. So it was just an example of overfitting. And now my slides are stuck. Okay, so yeah, this is what I was trying to explain about the simulation, where you would split the data sets into 10 folds and then fold one fold out, and then develop the model on the remaining 9 folds, and then repeat this, 10 times. It helps, minimize overfitting. And this is the example of overfitting that I was trying to explain. If you have a data points here on the left, the black line fits the data really well, but the green line is really capturing all the noise and nuances of the data. So it's too specific to the data at hand, so that when you apply it to a new data set, it's it's impossible to generalize. So moving on to how we would actually use this regression model in Stata 17. So this is your command. The command is Lasso, followed by logic, and then followed by your outcome, which is depression in this case, and then your list of predictors. And then at the end, you have the options of telling Stata what you want it to do. So the selection CV option, and as well as the false 10 option allows you to select lambda by 10-fold cross-validation. And then the cluster option, cluster with the name of the cluster ID variable in brackets, tells Stata to account for potential correlation between observations in the same clinic, since participants were grouped and nested within clinics in this data set. And then the RSeed number just helps you to ensure reproducibility of the results when you run this model every time. So below it shows the output of what you will get after you run this Lasso logistic regression model. So you can see here that the selected lambda is 0.0415, and the number of predictors that are retained in the model is 6. And you can see here that lambda was selected via cross-validation. So after you've run your Lasso logistic regression model, you can do some post-estimation commands. So one of them is to store your results. So you can run the command for estimate store, and then you would give the name that you want to store the results in. So I've given it the name depression cluster. And then if you want to display, the coefficients of the predictors that are retained in the model, you can run the command Lasso coef, followed by the name name of the variable in which you have stored the results. And then you have the options of, how you want, which type of measures you want to display. So the display coef penalized, sort coef penalized is basically telling Stata to display the penalized coefficients of the unstandardized variables. And it's sorted by the size of the penalized coefficients. So you can see here that the 6 predictors are retained in the model. And the combination of these 6 predictors would best predict the outcome depression. And we have the hopelessness, HIV stigma, social support, child poverty, family cohesion, and adherent self-efficacy, all contributing to predicting the outcome. So after you have another post-estimation command you can run is the predict command. So you run the command is for predict, followed by this double here is basically just the type of variable you want to store the results in, and followed by depression. This is the depression cluster is the name of the new variable in which the predicted probabilities will be stored. And then comma PR. So the PR option tells, it basically gives the probability of a positive outcome when you run the predict command. So we have specified our model. We have estimated the model parameters and we've run the predict command. And now we want to know how well this model is performing. So we're going to look at things like calibration and discrimination, as well as validation of the model. So for model calibration, calibration is basically the agreement between the observed rates of depression and in the data set and the predicted probabilities of depression. So to do so in Stata, you can fit the command, the calibration belt command, followed by the binary outcome variable, which is depression in this case, followed by the predicted probability variable, which we created earlier when we ran the predict command. So that's depression cluster PR3. And then you have these options at the end of the syntax. So the devel internal basically specifies the type of calibration, whether it's internal or external. And then the different, you're going to estimate this at different confidence intervals. So at 95% confidence and at 99% confidence level. And this command gives you a calibration belt plot, and along with a p-value, which is a test of how the agreement between the depression, the actual rate of depression and the predicted probability of depression in the data set. So this is the plot that you would get when you run that command. So you can see here, this is the calibration plot. And so what we want is for the observed rates of depression and the expected rate probability of depression to line up nicely. And we can see it does do so in this example, in that both the observed and the expected rates of depression are lining up on the 45-degree ideal line. And this is backed up by the p-value of being quite large, which states that there was no difference in this from the 45-degree ideal line. And then another type of model evaluation is discrimination. So discrimination basically looks at how well the model can differentiate an adolescent with depression from those without. And this is measured by the area under the receiver operator characteristic curve. And since prediction modeling is concerned with how well the model will perform in new cases or the generalizability of the model, we're also going to estimate this using 10-fold cross-validation. And this helps to generate a more realistic estimate of the predictive performance in new cases. So the command to get the AUC using 10-fold cross-validation is the CVAUROC. And you would follow this by your binary outcome variable, which is depression, followed by your predicted probabilities outcome variable. Predicted probabilities variable, the depression cluster 3. And then the options at the end of the syntax, the K-fold 10 basically tells Stata to split the data into 10 random folds. And then the seed with the random number just ensures the reproducibility of the results. And the graph lowest option at the end, it shows the mean, the average area under the curve for each of the 10 folds in which you split the data into. And as you can see from the output here, you get the AUC generated using each fold. And then at the bottom in the table, you get the mean AUC, which is 71 in this case. This corresponds to a good model, a model with good discrimination, since the rule of thumb states that an AUC of 0.5 is the same as chance, and an AUC of greater than 0.7 is a good model, and an AUC of greater than 0.8 is a strong model, and an AUC of 1 is a perfect model. So for the AUC, we want the line here to be as high above the chance line as possible. So the red solid line shows you the mean AUC from all the different runs, and the dashed lines, different colored dashed lines, correspond to each time you do the AUC in a fold. So there's also an alternative way to estimate the AUC in Stata using the ROC-reg command. And again, you would specify the binary outcome followed by the predicted probability outcome variable. And you can also, since this data is clustered, there's an option to control for clustering by the clinics using the cluster and name of the cluster variable command. And then you also specify a random number for doing the bootstrap resampling. And this is the output from the ROC-reg. And this is the plot that you would get for when the command you would do to get this plot is ROC-reg plot. So yeah, that's basically what I wanted to show you, some of the techniques that you can use in Stata to estimate a Lasso regression model. And I'd also like to refer you to this paper that has been published in the Journal of International AIDS Society, which we use similar techniques such as this one that I've described before. And this one, focused on predicting the individualized risk of poor adherence to ART medication among adolescents living with HIV in Uganda. And it's from the same SUBI adherence data set. So do check it out when you get a chance. Yeah, so I'll stop here for any questions or comments that you may have. And again, thank you for the opportunity to share.
Thank you, Rachel. That was really wonderful. And my compliments to you for braving a very difficult technological challenge here. So, and thanks again to Rochelle for all the troubleshooting. And this was really wonderful just to actually see how a machine learning application can be done in Stata and see the calibration plot and your various model validation tools. I did see in the chat, Wendy Hartigensis had a question. She asks, can you clarify, did you select the first complete record with or without depression from each individual? She goes on to say, I recall you had measures across time points and I thought those were repeated measures. Does your model use only one observation per person?
Yeah, so I forgot to mention, so the predictors, we selected them at the 36-month follow-up time period, so wave 3. And we assessed the outcome at the wave 4, the 48-month follow-up time point. So the predictors were measured before the outcome happened. So we didn't use the data set that comprised, all the repeated measures from each participant. So yeah.
That's great. You're able to maintain temporal ordering between the predictors and the outcome.
Yeah.
Other questions for Rachel?
I have a question.
Please.
Hi. Oh, maybe I'll turn on my camera. Hi, Rachel. Welcome. How would you, so this was great, but you mentioned in the beginning external validation. So have you done that in Stata and how does that work?
Yeah, so that's one thing that we have not done yet in Stata, simply because we need an external data set to actually do the external validation. And that data set needs to be as similar or closely related as possible to the one that we use to develop the model. So in that data set, we need to choose, predictors that are similar to the ones that we have selected. And, of course, there'll be challenges such as, data harmonization when, selecting the predictors from that data set itself. So that's like the next step following on to to this after you've done the internal validation. You need to now get a new data set and test it in that data set to see how well the model applies. But yeah, I have not done that as yet.
Okay, thanks. I bet there are some researchers in this group who could get you some good data on that.
Yeah, that would be really lovely. Thank you.
Thank you, Judy. I see Santiago has his hand up. Would you like to come on the line and ask your question?
Okay. Thank you, Rachel, for the wonderful presentation. At some point, I heard that you mentioned all the records are full records, which means we don't have any empty data, or what's the exact meaning for that? So are the 563 cases full record?
Correct, yes.
So a question, I guess I'm hearing an implied question here, maybe that what are some ways to handle missing data? Would that
Yes.
be accurate, Santiago? Yeah. So you're
that's correct. Yeah. How did you handle the missing data? Are we talking about 563 records with full data, or I misunderstood something?
Yes, yes. So in this example, I just used the complete data set, but in this paper that we have published here, we did do a sensitivity analysis where we imputed for missing values, but that was done in SAS using the expectation maximum algorithm. And Tor was really the one who really helped me out in generating that in the SAS package. But you can read more about how we handle it in this paper here. But just to say that the results were fairly similar to what we had found when we did use the complete case analysis, with the exception that there were a couple of the additional predictors that were retained, but the same ones that were retained in the original analysis were also found in the one where we included the data set with imputed values. I hope that answers your question.
Yeah, and for what it's worth, at the most recent Stata user conference, I recommended to Stata Corp in the suggestions for developers section that they boost the missing data handling options with Lasso in a future release of Stata. So hopefully they'll consider doing that.
Mm-hmm. That'll make a whole lot of difference, sort of using different packages, etc.
Other questions for Rachel?
Yes, I will share the slides to the presentation. Thank you.
Yes, we'll put those up on the CAPS Methods Core website, and along with a copy of the recording. All right, well, I'm not seeing any further questions from the audience, so why don't we take a moment to put our virtual Zoom hands together for Rachel and thank her for a really wonderful presentation. I know for me, I was really looking for a presentation that would show us how to actually use Stata to do an application in machine learning with HIV data, and this certainly met and exceeded my expectations for that. So this is really fantastic. And so Rachel, thank you for letting me cajole you into giving this presentation.
No problem. Thank you. I appreciate it and enjoyed it very much.
And Rachel, if people have follow-up questions, is it okay for them to reach out to you via email at Washington University at St. Louis?
Yes, please do.